Welcome, dear students and young intensivists, wherever you are. So today we have an international faculty webinar, and we have a very distinguished faculty from Ireland, and he's Professor John G Laffey, and he's done some great work on prone ventilation. So he'll be talking on prone positioning, both in awake as well as intubated patients in ARDS and in COVID ARDS, and what we have learned from COVID ARDS, especially awake proning. So Dr. Laffey is known to most of you, but nonetheless, I'll introduce him. He is a professor of anesthesia and intensive care medicine, School of Medicine, University of Galway, Ireland. He is scientist, remedy, QM, University of Galway, consultant anesthesia and intensive care medicine, Galway University Hospitals, director of clinical research, Saulta Hospital Group and University of Galway, and a testimony to the great amount of work he has done in his career are 500 publications, 35,000 citations, and a remarkable H-index of 91. So we really thank you, sir, for joining us and taking this webinar and educating us.
Thank you very much, Dr. Bansal. I'm delighted to be invited. Thank you. Yeah. So I will share my screen.
One moment.
Yeah.
Yeah.
Ah, super. Yeah.
Right, sir.
Okay. So, okay. So you can see my screen there?
Yes, sir.
Excellent. Okay, so I'm delighted to be invited to talk. As Professor Bansal said, I'm going to talk on prone positioning, both classic prone positioning in invasively ventilated patients and awake proning. So there are lots of links between Ireland and India. Historically, we have a similar flag, but we are opposite ends of the globe and also opposite ends in terms of size. Ireland is tiny compared to India, but it's a, you know, I have been privileged to visit your country, and I'm delighted to be giving this webinar. These are my conflicts of interest. I do research on cell-based therapies in the laboratory, so I collaborate with some companies, and I'm grant funded by the European Research Council and grant agencies in Ireland and in Canada. So what I wanted to sort of work through today was prone positioning. And
Dr. Laffey, one moment. Are
Yes?
you full screen, sir? Is your screen full screen?
Yes, it should be.
No, a small slide is showing on the side. Is that okay on this?
Oh, okay. Let me stop sharing for a second.
Yeah.
See what's happening here. Sorry now, excuse me. Okay, hold on. Is that better?
Yeah, now it's perfect, sir. Now it's okay.
Okay, my apologies, sorry. So what I wanted to do was to talk about the physiologic rationale for proning. And then talk about the evidence that exists for proning in invasively ventilated patients, and then move to talking about the experience during COVID and the work done on awake proning, because there are still some issues around the optimal population to awake prone and the factors that influence success in patients who are awake prone. And then to talk a little bit about the summary and the future directions for prone positioning. So in terms of the physiologic rationale, I think we're prone positioning in invasively ventilated patients has been in use for a long time. This is one of the first descriptions back in 1976, so almost 50 years ago. And so it has been used in individual isolated cases for quite a considerable period of time. And in terms of the rationale, we are familiar with the idea that most of the lung is at the dorsum, and when a patient is supine, as you can see here in these CT scans, what you see here, this is a patient with at a PEEP of 5 centimeters of water, and you can see there's a lot of collapse at the dorsum of the lung. This is the same patient at a PEEP of 15, and again, it's improved and there is recruitment of the lung, but there is still a significant collapse there. This patient, when proned, what you see is the dorsum of the lung, which is now in the upper position is much more open. And so this leads to better oxygenation and better matching of ventilation and perfusion. And you see this both at 5 centimeters of water PEEP and also again at 15 centimeters of water PEEP. And so this is the physiologic rationale, opening up lung units in the dorsum of the lung that have been collapsed due to the ARDS. This is data from COVID-19 patients. Again, these are invasively ventilated. And what this is using is looking at CT images and also then a perfusion ventilation scan using tomography. So what you see here in the patient in the supine position, you see the lung is reasonably open anteriorly with some pneumonitis dorsally. But when you look at the ventilation and perfusion, the anterior part of the lung is not perfused. So there's a big dead space. And when this patient is proned, what you can see here is the blue is the ventilation and the red is the perfusion. And you can see that there is much better matching of ventilation and perfusion in these patients. And this is interesting in COVID because we have this endothelitis that we see where you see big perfusion deficits in the lung. And so in terms of pulmonary effects, we know that prone positioning improves regional ventilation in the dependent lung regions. It improves matching of ventilation and perfusion. It reduces airway closure in the dorsal lung. It can also help with removal of secretions from the lung, and it increases lung volumes and improves diaphragmatic function. So these are all positive benefits physiologically in patients who are in the prone position. There are also beneficial extrapulmonary effects of prone positioning in invasively ventilated patients, particularly in terms of the cardiac system. So prone positioning offloads the left ventricle. It tends to improve cardiac output. It enhances systemic venous return and improves right ventricular preload and reduces afterload. So it tends to improve cardiac function, and it also has beneficial abdominal effects by reducing the pressure on the dorsal lung. But you have to position the patient very carefully in order to remove the risk of increasing the intra-abdominal pressure. So it is a modality that has multiple effects across different systems. So what about the clinical evidence for prone position in invasively ventilated patients? Well, as I said, the modality has been in use since the late 1970s, but the data to show that it was effective took a long time to emerge. And the initial studies, mainly done by Luciano Gattinoni in Milan, didn't prove that the prone positioning was effective. This is one of their first studies in 2001. And you can see here in the survival curve over time, the supine group and prone group, there is no difference between the groups. And in this study, they proned patients for 6 hours a day for 10 days. They did see in the sickest patients, those with a P to F ratio less than 88 or below 100, that there was an improvement in a post hoc subgroup analysis. But in the overall study, there was no benefit. They then did a follow-up study. This is again in more severe ARDS patients, so patients with a P-TEF below 100. And these patients were proned up to 17 hours a day for a mean of 10 days. And again, you can see here that the prone positioning did improve survival, but this was not statistically significant. When they looked at the ventilation that these patients received, it was clear that the prone patients received the same ventilator settings as the supine patients. So the plateau pressures were the same, PEEP was the same, tidal volume was the same. And so there was no adaptation of the ventilation following any changes that the prone positioning had caused, any benefits. Another international study then, again with a large Italian group, but also in Italy and in France, or in Spain, I should say, and in France, again focused on patients with moderate to severe ARDS. What they saw was in the entire population, there was a trend to a benefit of prone positioning, so a trend to an improved survival, but not statistically significant. Now, when they looked at the patients with severe hypoxemia, so PTF below 100, there was a clear signal in that subgroup for benefit of prone positioning. However, this was not statistically significant because the numbers were not big enough. So a meta-analysis was then carried out looking at the studies up to that point. This was in 2010 by Sachin Sood and colleagues, and they found that in the group of patients with the PTF ratio less than 100, so this group here, there was a benefit in survival with prone positioning. So at 2010, this was the state of the data. So no single trial was positive. There were trends to benefit in the patients who had low PTF ratio, and in a meta-analysis, there was a benefit. So this is the key trial in using prone positioning in invasively ventilated patients with ARDS. It's the proseva trial, and Claude Guérin in France was the chief investigator. So they looked at severe and confirmed ARDS. So they had patients who had their PTF ratios and criteria checked 12 to 24 hours apart, so on day 0 and day 1. If they still had a PTF ratio below 150 and were on receiving an FiO2 of 0.6 or more and had a PEEP of 5 and had low tidal volume ventilation, then they were enrolled in the study. They were prone for long periods of time, at least 16 hours, unless there was a complication or it was not effective. And what they saw was a big difference in survival. So prone positioning group had the supine group, which is a moderate to severe ARDS, had a mortality of 41%. And that would be consistent with mortality in that patient subgroup generally. So the benefit with prone positioning, the decrease from 41 to 23.6% appears to be due to the prone positioning. So this is the key a multi-center international study demonstrating the prone positioning is beneficial in invasively ventilated patients who have severe, moderate to severe confirmed ARDS. So why did proseva show a benefit when the other studies showed no effect? So the first thing is patient selection. So these are patients with severe and confirmed ARDS. So they waited 24 hours to identify the patient population. So these were people at much higher risk of death than the standard day 1 ARDS patients. They dosed the prone positioning in a way that optimized it. So there were long periods of prone positioning. They started early once they were enrolled, and then if it didn't work, then they stopped using the prone position. And they weaned or reduced the intensity of the mechanical ventilation. So they were able to reduce tidal volume, reduce minute ventilation in patients when they were put in the prone position. So they were able to more protectively ventilate the patients. And they had a good outcome for this patient population in the control group. So a 41% mortality in the severe confirmed ARDS is quite a good outcome. And they were very experienced in the use of prone positioning. So prone positioning in France, Italy, Spain, was widely used at the time of this study reporting in 2014. And so they were able to do it safely and effectively with very little complications. There are some caveats, and in regard to the study, it is a single multi-center study. It's an international multi-center study, but it is just one study. The effect size was large, and there was a difference in cardiac arrest rates between the groups, where prone positioning seemed to reduce the risk of cardiac arrest. Now, we know from later studies about the beneficial effects on the cardiovascular system, but at the time that was a little bit surprising. Nevertheless, in our patients who are invasively ventilated with classic ARDS, prone positioning is standard of care. It's interesting to see that it is relatively underused, and certainly before COVID, only a minority of patients globally were receiving prone positioning. And that's been shown in the LungSafe study, where less than 10% of patients were proned. So COVID-19 and COVID-19 ARDS really changed the landscape in many ways in lots of aspects of our care of these patients, including in prone positioning. And this in part was because there was a huge priority to reduce the need for invasive mechanical ventilation because of the numbers of patients suffering from COVID-19. And so lots of different strategies were looked at. And one of the strategies that was examined in detail was awake prone positioning. So awake prone positioning is where you take a patient who is on a prior to invasive ventilation and you put them in the prone position, and your aim is to keep them off the invasive ventilator, so to reduce the need for invasive mechanical ventilation. There were some studies prior to COVID-19. This is work from an Italian group in 2009, where they had a case series of patients whom they were able to use either non-invasive ventilation or CPAP, helmet CPAP, and have them awake and have them in the prone position, and showing that it was feasible. This is a second report from 2015 from the Milan group, Professor Pezzenti and colleagues, again showing that awake prone positioning was feasible in patients with acute hypoxemic respiratory failure, and that when you proned people, that their P to F ratio improved, and then when they came back into the supine position, that decreased again. One of the key things that had changed in the time prior to COVID-19 was the introduction of high flow nasal cannula oxygen. So this is a technique where high flows of humidified oxygen at a titratable FiO2 can be delivered via nasal cannula to an awake patient. And this has been shown to be comfortable, easy to tolerate, and a useful modality in patients who are failing conventional oxygen. There's nice data to show that patients' work of breathing decreases with high flow nasal cannula. So this is standard therapy. These are the resp rates prior to high flow nasal oxygen. And then these are the resp rates after the introduction of high flow nasal oxygen. And you can see they decrease while arterial CO2 rates stay stable. So it suggests that high flow nasal cannula oxygen optimizes ventilation and reduces work of breathing. And this has been widely used sort of globally in many countries just around the time of the start of COVID-19. And this is data from a French study called the FLORALI study. And again, they looked at high flow nasal cannula in patients with acute hypoxemic respiratory failure. And they compared this to non-invasive ventilation and to standard oxygen therapy. And what you found in the entire group was that high flow oxygen had a reduced risk of intubation compared to either non-invasive ventilation or standard oxygen. What was a little surprising here was that non-invasive ventilation performed relatively poorly in this study. Now, when you looked at the patients with a P/F ratio less than 200, you saw that there was a statistically significant reduction in the need for intubation in high flow nasal cannula. So the work that I and others were involved in was looking at the combination of high flow nasal cannula oxygen use in patients with awake prone positioning to reduce the need for invasive mechanical ventilation. So in terms of the evidence base, this developed rapidly during the COVID pandemic and is still developing. But the patient population that people focused on varied depending on the type of oxygen support that these patients had. So the group that we worked with were looking at patients with high flow nasal cannula oxygen. So they were COVID-19 positive. They had respiratory failure, as evidenced by a P/F ratio less than 300. They were in a critical care setting, so this was not ward level. This was an ICU type environment, and they were able to awake prone. The control or the standard of care was no prone positioning. And the outcome was the need for invasive mechanical ventilation. So we first issued a call for other countries doing studies of awake proning to come together to develop a meta trial. And we were able to get 6 different trials that were in progress, one in Ireland, one in France, one in Spain, one in Canada, one in the US, and one in Mexico, to harmonize their protocols and work together in this meta trial. And the meta trial is different to a meta-analysis. A meta trial is where you take the trials and you have a single result at the end of the trials. So we don't do the work afterwards. A meta-analysis takes the data after the trials are finished and does an analysis. This is while the trials are ongoing. So we take the trials, they come together, they harmonize their protocols, so they have the same outcome, same intervention, and then they upload their data to a single repository. And then an ongoing analysis is done. And then when the study hits its predefined criteria for efficacy, the studies are all stopped. And they report a single paper, a single result. So this is the finding from the meta trial. So this was published in the Lancet Respiratory Medicine, and it was the 6 trials, and 1,100 patients were randomized, around 560 to awake prone and same to standard care. And then the outcome measure was survival without invasive mechanical ventilation. What we saw was that in terms of the risk of treatment failure, so treatment failure would be either death or invasive mechanical ventilation. And what we found was that awake prone positioning reduced treatment failure. And this was a highly significant result, with the number needed to treat to avoid intubation or death being 14. And when we just looked at intubation alone, most of the benefit was seen in reducing the need for invasive ventilation. When we looked at mortality, there was not a big difference in mortality, or there was no difference in mortality between the two groups. So it was not a benefit in outcome, but it was a benefit in reducing invasive ventilation. And there was no difference in weaning from high flow cannula. What we saw was when we looked at the effect of awake prone positioning was that when you looked at just prior to prone positioning, 1 hour prior, and then during prone positioning and after, you saw that S to F ratio improved during proning and then reduced down, but did not get back to the same level as the pre-prone positioning. So there was an effect, an ongoing effect of having been prone. So even after you returned back supine, your oxygenation was better after than it had been before you were proned. We also found a similar thing with respiratory rate. So there was a sustained reduction in respiratory rate in patients who were proned, even after they were turned back to the supine position. And the ROX index, which is a mixture of oxygenation and respiratory rate, was also had a sustained improvement. We did find variability in the amount of time people proned for. So this looks at the number of patients and the time periods for which they proned per day. Now, we encourage patients to prone for at least 8 hours per day, but as you can see, most patients were not able to achieve that. And when you look here at treatment success versus treatment failure, what you see is the longer time patients were able to awake prone for, the higher the success rate. Now, there's 2 aspects to this. One is if they were in a unit where people, encourage them to stay prone for longer, then that may be the effect. But also, some people were better able to tolerate prone positioning. And so the people who could tolerate for longer had better success rates. This is an analysis done from the meta trial where we looked at the duration of time of awake proning. So one of the concerns would be that awake proning would delay intubation and that then these patients would have more injured lungs. and that they might do worse, that subgroup. But we didn't really see any evidence for that. So this looks at the likelihood of failure of awake proning and high flow over time. And what you see here is that, and this is days up to 14 days, what you see is there is no increased risk over time. So there doesn't seem to be a signal to suggest that these patients have a deferral of intubation, but then just end up needing to have invasive ventilation anyway. The effect seems to be sustained, and the risk is stable over time of needing invasive ventilation. And so what we found was that in terms of outcomes, in the people who got invasively ventilated, so we looked at, if you had awake prone positioning and you needed invasive ventilation, what was your survival compared to the group who were in the standard care group who got invasively ventilated? And what we saw was there was basically no difference. So mortality was the same, and the duration of mechanical ventilation was the same. So once they were ventilated, even though it may have been delayed, their outcomes were similar to invasively ventilated patients in the control group. So again, that speaks to the safety of awake proning. So it's not a case that we are delaying intubation and then that might cause harm to a subgroup of patients. So there's been a lot of discussion about the right population for awake proning. Our study was done in patients who received high flow nasal cannula, but studies have been done on conventional oxygen therapy and as well. And so we want to try and understand, which groups does awake prone positioning work best in. So this is data from the US. It's Todd Rice and his colleagues, and they looked at awake prone positioning at ward level in their study. So they had patients who were predominantly on conventional oxygen therapy. So you can see 2/3 of the patients were receiving low flow oxygen, and then a small proportion were getting high flow or non-invasive ventilation. So this is predominantly a ward level study in patients on conventional oxygen therapy. And what they found at day 5 was no effect of awake prone positioning. In fact, if anything, the rate of death was slightly higher in the group that received prone positioning, and discharge was slightly lower. Now, when you went out to day 28, there was no difference between the groups, but awake prone positioning in this study was not effective. And so this disparity, or these different findings in the literature, have led to confusion, I think, in regard to what patients would benefit from awake proning. So to try to address this issue, our group, which is the group to perform the meta-analysis at the meta-trial, also then did a meta-analysis of all the data and studies with awake proning. So we looked at ultimately 29 different studies. 10 of them were trials and 19 were in observational studies, looking at awake prone positioning in all patients with COVID-19 respiratory failure. And what we found overall was that in the entire group was that if you required intubation, awake proning reduced the need for intubation compared across in all patients compared to conventional treatment, but it did not reduce the risk of death. So again, similar to what we've seen in the meta trial, but this now is in sort of 29 studies. We looked at the type of support that the patient was receiving. So again, this looked at advanced respiratory support and oxygen therapy. And what we found was that advanced respiratory support reduced the need for, awake prone positioning reduced the need for intubation in patients with advanced respiratory support, but it did not reduce it in patients receiving oxygen therapy alone. So you needed to be sufficiently unwell to require advanced respiratory support. So that's high flow, nasal cannula, non-invasive ventilation, or CPAP. In the group that were just required oxygen therapy, there wasn't an effect of prone positioning on intubation rates. Now, part of this is because the rate of intubation is low in that cohort. So if you're trying to focus on the group most likely to respond, then it's the group that need higher levels of respiratory support. We also looked at where the patients were cared for. And what we found is that if you were cared for in an ICU type environment, now it didn't have to be an intensive care unit. It could be a ward where you had ICU level care, so you could extended your ICU out to the wards. Those patients benefited from awake prone positioning, whereas patients on general ward level did not show a benefit. Now, we think this is probably because of the fact that awake prone positioning is quite resource intensive in terms of personnel. So you need a nursing team or a team of people who will help to prone the patient, who will monitor the patient in the prone position, encourage them to stay prone. And this is labor intensive. And that at ward level, there probably isn't the resources to do that. And so then in terms of factors that affect the success, so it appears that it's most likely to be successful in patients who have advanced respiratory therapy, who are cared for in a higher care environment, be that an ICU or an ICU type setting, and who have lower oxygen levels. We want to look then about the proning itself. So this is data from our own meta trial. And what we've done here is we have divided up the patients based on the study. So the Canadian study, the French study, the Irish study from Mexico, Spain, and USA. And what we're looking here is the duration of proning. And what you see is there is a difference across the countries. Even though we have the same protocol, there's a difference across the countries in terms of the amount of time the patient spent in the prone position. So we want to look here for a moment at, say, France. So France had a median prone time of about 2.5 hours. And you can see here in the outcome for reducing the risk of intubation by country, there's a trend to a benefit in France, but not a clear benefit. And if we look then at Mexico, Mexico had the highest periods of time with awake prone positioning. So they had median times of about 8-9 hours. And when you look at those patients, what you see is there's a clear benefit of awake proning in the patients with a longer time period. So some of this at least seems to be due to the particular approach of the clinical team. So in Mexico, they really worked very, very hard to have people stay in the prone position for as long as possible. Whereas in other countries, in other trials, it was less enforced and more up to patient choice. We then looked at patients who were had worse oxygen levels. So we looked at patients with an S to F ratio of greater than 190, which is around about a P to F ratio of 150, versus those below. And what you find is that the sicker patients, the patients with the lower S to F ratio, are the ones that have the best benefit. So they're the ones most likely to benefit from awake prone positioning, which may be a little counterintuitive because these patients are sicker. They might find it harder to tolerate being prone, but if they can do awake proning, they're more likely to benefit from the awake prone positioning. This is data from the subgroup enrolled in the study in Mexico. So this was published to try to show the factors that enhance that are associated with success rate. So we looked here at respiratory rate. This is the group that was successful and did not require intubation or didn't die, versus those that were prone but did require either to be intubated or who died. And what you see is the effect on respiratory rate. At baseline, they have a lower respiratory rate, which is important, but it decreases and stays reduced in those patients who are successfully awake prone compared to the group who are not successful. So there's a bigger drop in respiratory rate, and it is sustained. And you see similar effects with S to F ratio. So there's an improvement with proning, but there's some degree of sustained improvement in the patients after they've returned to the supine position. And then the ROX index, which is the S to F ratio divided by the respiratory rate, you see the sustained improvement in the successful patients, whereas there's a drop back close to baseline levels in those who weren't successfully proned. This is data from lung ultrasound at day 1 in enrollment and day 3 in a subgroup in the Mexican study. And what you see is the patients who successfully proned, their lung injury was reducing over time, whereas those that ultimately failed, there was no decrease in the lung injury. So the other subgroup that we looked at in the Mexico cohort was the patient group who were so-called silent hypoxemics. So these are patients who had low oxygen levels, but didn't have clear severe respiratory distress, so not very high respiratory rates or dyspnea, and we compare them to the standard more dyspneic hypoxemic patients. And the first thing you see here is that the silent hypoxemic patients are able to prone for a lot longer than the patients who have dyspnea. And this kind of makes sense. When you put somebody over awake, you put them in the prone position. If they're short of breath, they find it harder to tolerate, and they tolerate it for shorter periods of time. And what we found then when we looked at the success rates as a function of the duration of proning in the group from Mexico, we found that if they could prone for sort of 10 hours or more, almost all of these patients were successful. Whereas if they proned for 6 hours or less, most of these were unsuccessful. So the duration that they were able to prone, or the duration the team were able to encourage them to stay prone, was important in the success. And we were able to look at the probability of success of awake proning as a function of the amount of time spent in the prone position. Now they could spend short periods of time prone and then go supine and then go prone again. They didn't have to spend like 8 hours prone. They could do a half an hour prone, come supine, go prone again. It's the total amount of time in the 24 hours that seemed to be important. And so you see there's a linear relationship between the amount of time spent prone and the success rates in avoiding invasive ventilation or death. And then what we looked at here was we divided patients into whether they spent 8 hours or more in the prone position, or they spent less than 8 hours in the prone position. And you see those who spent 8 hours or more in the blue line had a much higher probability of survival without intubation compared to those who weren't able to spend that length of time. So they were less than 8 hours. And we saw this was true also for mortality. Just looking at mortality alone, this is the one study that shows an effect of awake proning on mortality. So if you are able to spend at least 8 hours in the awake prone position, you have a lower mortality rate compared to those who were less than 8 hours. So in terms of where we are with prone positioning, I wanted to first talk about prone positioning as a summary in those who are invasively ventilated. So, you know, as I've shown you the studies, the Gattinoni studies and the studies from France and the proseva study, and they all sort of have developed a strong evidence base for prone positioning in invasively ventilated patients with classic ARDS. So our practice and a lot of people's practice at this point is to prone any patient who has a PTEF ratio less than 150 in the first 24 or 48 hours of ARDS, and then to continue to prone them for at least 18 hours, 16 hours a day until they are ready to wean from mechanical ventilation. And basically, you know, awake prone positioning is now standard of care in invasively ventilated patients. Although its introduction across the world has been quite patchy, at least up until COVID. Interestingly, there aren't any trials in prone position of invasively ventilated patients in COVID-19 ARDS, and this is probably because of clinicians did not feel that they had equipoise. So they extended the data from classic ARDS to COVID ARDS and simply in large numbers proned patients with COVID-19 ARDS. But interestingly, there is data from observational data sets, big observational data sets, that don't clearly show a benefit of proning these invasively ventilated patients. So interestingly, prone positioning of invasively ventilated COVID patients is actually decreasing. And I think that's just to sort of make this point a bit more strongly, I think that's a point that needs to be addressed. I think we need to actually relook at some of these studies, the observational data sets and the observational studies. One of the critical problems with them is they don't make a clear distinction between timing of prone positioning. So they tend to look at, were you prone at any time during your COVID-19 illness? And we know that proning, the evidence base for in invasively ventilated patients is for early proning. So we use proning either early as a treatment or late as a rescue. And the data for rescue proning is very unclear, right? So the studies, the observational studies so far don't really tease out that issue. I think it does need to be addressed in studies. What about awake prone positioning? Well, I think there is a growing evidence base for awake prone positioning in the right population of patients with COVID-19 ARDS or acute respiratory failure. It reduces the need for invasive ventilation. It does not have a big effect on mortality. There are no good studies. I showed you the study from Mexico showing that prolonged awake proning seems to reduce mortality risk compared to shorter periods of proning, but the evidence for mortality is not that strong. The evidence is strong for reducing the need for invasive ventilation, which in a pandemic situation is obviously very, very important. But there is limited evidence outside of COVID-19 ARDS. There are some case series, but again, no trials. So this is something we do need to look at in patients with classic ARDS and to see if this would be a useful modality in these patients. So in terms of future directions then for prone positioning, I think we need to expand the evidence base for prone positioning in invasively mechanically ventilated COVID-19 patients. It may be too late to do a trial, I think, in this situation, given where the pandemic is. But I think that there is very good data in databases that we need to relook at and look at timing of the prone positioning. And we need to expand the evidence base for awake proning outside COVID-19 ARDS. So would it work in pneumonia or in ARDS? And I think we need clinical trials in this area. In terms of the target population for awake proning in classic ARDS, I think we can probably apply some of the lessons from COVID-19 and look at long durations of proning, at least 8 hours, and look at more severe patients, so patients with an STF less than 190 or a PTF less than 150 on high flow oxygen. Awake proning does seem to need to be delivered in a critical care type environment. So you do need good nursing and medical support for it. It does seem to work well in combination with high flow nasal oxygen. And it does seem that the population with silent hypoxemia respond best. Now, it remains to be seen how many patients with classic ARDS have silent hypoxemia. It's certainly not an entity we recognize in any detail prior to COVID-19. And I think we need to consider expanding the use of prone positioning to other types of acute respiratory failure. Certainly in our intensive care unit, you don't have to meet the criteria for ARDS to be prone positioned. And so we tend to prone position severe pneumonias, even if they don't fulfill all the criteria for ARDS. But that's a practice, that's a clinical practice in our intensive care unit. And I think it does, and I think, lots of people are using it outside ARDS, but we need trials to really show whether or not it is effective in those settings. So with that, I'll close, and I would be very happy to take questions from many of you. And thank you again for the privilege and the honor of giving this talk to this group.
Thank you, sir. Thank you very much. Lovely listening to that and wonderful insights. Thank you so much, sir. So if the audience has any questions, please type your questions. Sir will take the questions. So, sir, meanwhile, as we wait for any questions from the audience, just a couple of questions from my side. So we understand the physiology in prone ventilation in intubated patients. So in patients whom we do awake proning, right? What are the physiological differences in awake proning vis-a-vis ventilated patients proning?
So there are some studies looking at this. So particularly studies looking with imaging, and the effects seem to be very similar, right? So it's obviously a negative pressure system rather than a positive pressure system, but you're seeing better distribution of ventilation and perfusion in the awake patients who are prone. And so the physiology seems to be quite similar between both invasive ventilation and advanced respiratory support. And the reduction, I suppose one difference is you do see a reduction in respiratory rate in awake prone patients, which seems to be a benefit, which obviously you've set in the invasive ventilated patients, so that you don't see it as much. But the physiologic effects are quite similar.
So the reduction in respiratory rate comes from what, sir? Overall decreased minute ventilation, the decrease in tidal volume, or what, sir?
So a reduction so they tend to have a more normalization of respiratory pattern. So they have a reduction in respiratory rate, and they have better distribution within the lungs. So they are less, their work of breathing comes down, and the respiratory rate it decreases.
Right, sir. So then about the duration of prone ventilation in intubated patients. We have a cutoff at 16 hours, but there are studies looking at prolonging this 16 hours and getting better outcomes. Of course, you don't want to prolong it too much because studies have shown they get pressure ulcers. There is increased incidence of pressure ulcers if we go for too long. But can we go beyond 16 hours? Some kind of a practical tip you can give us?
So yes, I think that's a very good question. So people, the proseva study, which is where the 16 hours came from, the study actually prone for a minimum of 16 hours, but people tend to take the 16 hours as being, a fixed number. But there were patients in the proseva study that were prone longer. So our pattern, our intensive care unit, is to prone patients in the afternoon, then leave them prone through the night and unprone them in the morning before the rounds, so that we have the morning then to assess the patient, do our examinations, do our imaging, anything that we want to get done with the patient before we then reprone them in the afternoon. And that normally we prone for somewhere between 16 and 18 to 20 hours. But you are right. I mean, the downside of long proning is the pressure on the face and on the chest and so forth, and the risk of ulceration. But with practice and with a good nursing team, those complications can be reduced. So if it's necessary, if we have patients who are very unstable when they're turned supine, we will leave them prone especially for their first proning period, we can do it for over 24 hours.
Right, thank you, sir. So then about the hemodynamics. So if the patient is hemodynamically unstable, is it okay to do awake proning, or is it the same as the effect the intubated patients have when they are prone?
So the hemodynamic instability does complicate things, as does things like dialysis. So it's more difficult, obviously, to prone these patients because they're connected to more equipment, and they could potentially become unstable when you turn them prone. So some of this is about just how comfortable a unit is with proning. So we prone patients who are on pressor therapy. We prone patients who are dialyzed, but we have extensive experience of proning, so we're able to do it quite effectively. But there is an increased risk of hemodynamic instability during the turning period. But once you've turned them, and you treat that period of instability if it occurs, they will normally resolve.
Right,
So
thank you, sir.
we don't see that as a contraindication. We will prone them.
Right, thank you. So just a final question, sir. You have so much knowledge and experience about this awake proning. What kind of a practical tip do you give us? So many patients come to the ICU, with hypoxemic respiratory failure, whether it's ARDS or just respiratory failure, not ARDS. Should we do awake proning in all these patients, and does the device matter? High flow NIV, cot with high flow oxygen going on.
Mm-hmm. So one of the things we found was like prone positioning. I mean, it's a simple maneuver, but it's not. You need a lot of help. So you need a team. Even the awake prone patients, a lot of them, you actually need to turn them. right? So that was one thing we learned with proning the patients awake, is they needed help because of the effort of turning prone. So a lot of these patients will be a little bit overweight, and like it's quite a considerable effort to turn over onto your tummy. So we needed a team to help the awake prone patients, and we found that really helped a lot, because if they got short of breath while they were proning, they would lose confidence and then they'd want to come back supine. But if you helped them and they didn't get short of breath while they were proning, they were able to tolerate it more. The other thing we found was helpful is we made videos of people who had been prone positioned. We asked them to do videos explaining how they felt when they were turned prone, and then we showed these to the patients, the new patients, so they could learn from the previous patients. And they found that very helpful, that they saw somebody who had done this and now was better. And they said to them, like, I felt a bit scared when I was turned prone first, but I got used to it. So we used people who'd survived to teach patients about the practicalities of proning. And the third thing then was in terms of the devices. We found that the high flow worked really quite well with the proning, because they could be on their face and the little cannula would be under their nose and it wouldn't be hurting them or pushing into their face. So they were able to tolerate the high flow, better in the prone than, say, a non-invasive face mask. The other device we found that worked well was the hood. So the CPAP hood that was all the way over the head. People were able to prone quite well with that as well.
Great, sir. Thank you so much. Just last question, sir. Very important point, I think. Awake proning has shown that it reduces intubation rates, right, sir?
Yes.
But it does not reduce mortality. So what is the explanation for this? Is there any explanation? Can we understand anything about this?
So yeah, that's a very good question. So I think that, as I showed you with the data in Mexico, like I think the sicker patients, there probably is a benefit in mortality, right? So like mortality rates, from COVID, and thankfully, if you're treated in an intensive care unit, with sort of all the treatments that are there now, like the steroids and so forth, thankfully mortality rates are reasonably low, right? But in the sicker group, there does seem to be a benefit of long periods of awake proning. But you're right, the data is not that strong for mortality.
Okay, sir. Thank you, sir. So I think, sir, can we take home the message that if the patient is really sick, we should go ahead with the awake proning in all kinds of respiratory failure with due
Yes,
precaution?
I think if you've got patients who've got an S to F ratio below 190, so a P to F less than 150, they're on a high flow, or something similar, CPAP, and they're able to tolerate proning, I would prone them. I would give them a trial of proning.
Lovely, sir. Great, great.
Yeah.
So I thank, sir. With that, we'll come to an end. We thank you, sir. We, the people of Young Indian Intensivists, Indian Intensivists, and intensivists across the world, thank you for your time and this wonderful education on proning, especially awake proning, an evolving concept. And for all the audience, this will be up on our YouTube channel, and you can review it. Thank you very much, sir. It was an honor and pleasure. Thank you very much.
Thank you very much. Thank you, Dr. Banson. Thank you
Thank you.
for the honor. I really appreciate it. Good day. Bye now.
Bye, sir.